Good evening, everybody, and a very, very warm welcome to the Clinical London Masterclass in Interpretation of OCTs by Jen Anikina. I'm Jane Olver, and I'm chairing this tonight, but you won't see much of me. You're mainly going to see Jen, and she's actually called Evgenia Anikina, consultant vitreoretinal specialist and cataract surgeon. She works at Clinical London, and she also works in, is it the Royal Berkshire in Reading? And she's an amazing vitreoretinal surgeon. And I'm going to just sit back and listen and learn from her about OCTs. Let's get started.
Thank you very much, Jane, for that lovely introduction. I feel sort of a bit oversold, but we'll get cracking. This webinar is actually here today by popular demand. Last webinar we hosted, there were a lot of requests for an OCT interpretation session. So here we are on a request of the crowd. So without further ado, we're going to talk today about the OCT interpretation and the clinical relevance of such. My name is Jen Anikina. As Jane said, I'm a vitreoretinal consultant at Royal Berks. I also work at Clinical London, and in Reading I work at the Spire and also in Windsor. My backgrounds, I trained in London. I did my fellowships at Moorfields, 4 of them for my sins. I'm one of the principal investigators for clinical trials and research at RBH. Got lots of educational roles and a few other organizational roles. So that's who I am. So what are we going to talk about today? Well, I thought with our plan, I always like to do a little anatomy recap. I do like my anatomy. And then to think specifically about the different conditions. But before we think about the different conditions, I also want to recap a bit about the technology of OCT, because it's interesting, and I think we forget a little bit about how much work went into it. So without further ado, this is the system I will be using for the clinical cases throughout the talk. I borrowed this from a very kind colleague who gave me this good idea. So the red flag, yellow flag, and green flag or orange flag for lack of yellow. And they roughly mean the urgency of a potential referral for a patient. So red flag is really kind of 2 weeks or less. This is the super urgence. The orange yellow flag is the kind of sort of routine referral, really 2-3 month-ish. And green is, well, do we really need to review them at all? So OCT and normal anatomy of the retina. So here's a picture a lot of you may have seen about how OCT works. So OCT is basically ultrasound with light. So it sends light rays out, it bounces light rays off a surface, and then it picks up the result, and through some clever calculations, it works out what it's looking at. And the whole point of it is that tissue interfaces, so where the cornea interfaces with the anterior chamber fluid, where the anterior chamber interfaces with the lens, where the lens interfaces with the retina, and all the retinal layers, they all have different reflectivity of light. And so the intensity of the signal becomes proportional to the reflectivity. So something looks bright, it means a lot of light bounces off that layer, that interface. And the time or order of signals as they come back point to the depth. And that's how we get our picture in OCT. So originally it was used in the telecommunications industry. Carl Zeiss in '96 produced the first ophthalmic OCT machine, with the second generation coming soon after. These didn't really take off because they were very slow. But the third generation, the Stratus in 2002, was getting better. And then more modern machines came into use after that, the so-called spectral domain, which you may have heard. All the ones before that, before the Optiview in 2006, were so-called time domain. So what's in the terms? Time domain, spectral domain. Just a quick recap in case you've heard these terms and wondered. Time domain, this is back to the picture we had, and that's literally comparing using a little reference mirror which moves back and forth, and it's comparing how fast the light signal comes back from your retina to how fast it comes back off the reference mirror. And that lets you calculate the depth of all the retinal layers in the structures. Spectral domain, similar thing, but what it actually does is it uses the fact that the different wavelengths of light bounce off at slightly different angles because of their different energy. And in this scenario, the reference mirror is fixed in position. Some clever mathematics called Fourier domain calculations are used to calculate what we need to see. And then you get your nice stripy OCT picture. And spectral domain machines that use this principle are also able to image at greater depth, which you may have heard as EDI, enhanced depth imaging. So here we are, another picture of the same thing using time analysis, so analyzing the time for the signal to come back, versus frequency analysis for the two different time domain versus spectral domain machines. Swept sources is one of the newer ones, and basically what this is it's pretty much the same as the spectral domain, but it uses a very narrow band of wavelengths, which means it can be very fast, and it's also quite good at imaging depth, so down to the choroid. And then adaptive optics. I wanted to put this in here because I think it's really exciting. And I think it may be the future at some point. As it's technology borrowed from astronomy. In clever telescopes, they use sort of very clever computers and optics to correct for wavefront aberrations to get rid of that shimmering effect of the atmosphere. And this is an adaptive optics SLO machine. And I've worked on something very similar to this. In fact, this might be the very one I worked with at UCL. So it looks very far from clinical practice yet, but I think it should come because it gives you pictures like this. And this is in vivo, so real-time pictures of real rod and cone cells in the retina, comparing density. So the picture in the bottom right, that's a normal fovea. And the top left, you can see there's very sparse cone. So this is probably rods far out in the retina, and you can see them actually moving and changing and changing visit to visit. So and then this is something we're not going to talk about today, but I thought I'd mention it because it's a talk on OCT, and OCT is not just about the macula and the retina. We have angio-OCT, so allowing us to image vessels and the activity of blood vessels, choroidal neovascular membranes. There's disc OCTs, and you would have seen the outputs of that. And then there's anterior segment OCTs in use by glaucoma and corneal surgeons principally. We're not going to talk about those today. That would be too much for one talk. So back we come to our retinal anatomy. Just to remind you of all the layers, it's like a layer cake. And light has to travel through all of these layers to in order to reach the photoreceptors down there at the bottom. And here is those same layers in black and white. So this is the OCT breakdown. Now, I'm going to bring this picture up again and again throughout the talk. But now I just want to point out, if you're going to look at anything in an OCT ever, any OCT, look at this layer here. This layer here, that's the inner and outer photoreceptor segments. So these three arrows in the middle, because that's your most important layer, because it almost doesn't matter what's going on in the other layers. And we'll see that time and time again, how that bears out. Look at the photoreceptor layer, the bright line here, and what that looks like. And that will give you a lot of information. So here's our retinal layers overlaid on the OCT, and you see how nicely they actually correlate one with the other. It is literally optical section. It's essentially looking at a section of the eye, but using optics. So we'll move on to our clinical conditions now, the bit that you've all been waiting for. Macular edema. Now, who gets macular edema? What is macular edema? Well, you can get it in diabetics, of course, diabetic macular edema. You get it in the vascular occlusive events, central vein occlusion, branch vein occlusion. You get it as cystoid macular edema post-cataract, Irvin gas. I've put in post-VR surgery because obviously I'm a VR surgeon, it's a special interest, because I see these patients referred to me, and I'll show you what I mean later about what that means. And also, you know, there can be edema in other conditions. So here is a lovely central retinal vein occlusion with this very gross, very dramatic macular edema picture on the right. So you can see the tubulations, and you can see fluid under the retina, you can see fluid in the middle of the retina. We're going to look at this normal OCT scan at the bottom here again. Can you see how that layer I said was important, the photoreceptor layer at the bottom? That here is perturbed. You see all these little bumps. That layer is exactly the layer that things have gotten split at. So that might be a problem. Now, how urgently would you want to deal with this? If you had a patient walk in with this to your practice, how urgently would you want to refer? Well, this is probably only an orange, because by the time this has happened, you've got a little bit of time where it's not going to change much. So we'll probably want to see it within a month or so, you know, get it treated, but it's not a super urgent jump up and down sort of in scenario, because of course at this stage, the vein occlusion has become ischemic, so the eye has suffered already. So when we've got a few little quizzes and polls scattered throughout the presentation. So I'll go to this poll. So have a read of the quiz question, and I'm going to put the poll up for you to vote. So hopefully everyone can see that come up. I'll give you a minute or two to vote. Okay. Good, good, good. Good, good, good. Okay, high cholesterol is winning at the moment. History of cataract surgery. Hello, high cholesterol's gaining ground. Okay, I'm going to just end that there for the sake of time. And here we are. So the answer is history of cataract surgery. And this was a little bit of a, well, a slightly mean one perhaps. The first two are quite sort of reasonably generally accepted. The longer you've been diabetic and the worse your control, the more likely you are to have bad effects. High blood pressure is usually associated with all of this, and there is a well-proven association for that. Cholesterol, a bit more tenuous, but still shown. However, the presence of cataracts, rather than having had cataract surgery, incidentally, for some reason, is associated with more likely development of DMO. I don't know why that is, but it's been shown in some studies. So if they've had cataract surgery, no, but if they have cataracts, then they're more likely to have DMO. So we are going to move on. So DMO, length of diabetes, length of poor control, high blood pressure, cholesterol, and you've got this clinically significant aspect. So that's just from the DRSS grading criteria about what features you need to have in order for it to be clinically significant. This is really sort of an aged term. It's a term from past times when we used to look without having the OCT. Now with the OCT, it's much easier to assess the severity and the risk of the edema to the fovea, because that's essentially what you're trying to grade. You're trying to grade the risk to the fovea. So here we are. Here's a picture of clinically significant macular edema. And in terms of the locations of the lesions that you need to have, you all, I'm sure, would have seen that. And here are some lovely OCTs. So they both have little exudates on the picture, but in this one, the exudates in the top one, the exudates are quite far out and they're not near the center. And in the bottom one, they're quite near the center of the fovea. Here are the little exudates glowing. Okay, so the top one is not clinically significant. We're not really fussed about this because it's not going to affect the vision anytime soon. And diabetes is a chronic condition. Therefore, we were probably not going to get rid of them very readily. We're just going to monitor it. But the bottom one is clinically significant. We do want to see this. We want to see this fairly routinely, a couple of months, because it may worsen and it may be affecting vision already. And if not, it may start to do so. So this is the kind of DMO that is our heart sink DMO. And when we see this, we sort of know that there isn't going to be an awful lot we can do for the patient. We can try and reduce the fluid with injections, but the vision often is compromised. So you've got these inner retinal cysts which persist. You've got the subretinal fluid and outer retinal cysts. So the whole retina is quite sick. Okay, we do want to see this. but the effectiveness of treatment is often not great. So ischemic maculopathy, this is usually diabetic. It could be vein occlusion related. But look at our photoreceptor layer in the bottom picture. Where is it? It's gone. You can't see it. You can't see any of the nice layers and striations like you can on the right. I mean, you can sort of maybe appreciate the sort of the top layers, the nerve fiber and the ganglion cell layer, but you can't see any layers at the bottom. Here is the photoreceptor layer on the very left, just the very left of the picture, and then it just stops. This patient is going to have very poor vision. Maybe, I don't know, 650 count fingers or thereabouts. And there's not much we can do about this, because getting rid of the edema here will not improve their vision because they have no photoreceptors to see with. And this is an ischemic picture. This is long-term lack of blood supply due to some sort of vascular insult. So all of the structures are atrophied. We'll see it, but we'll see it mostly to ensure that they've had adequate PRP laser, so they don't develop neovascularization, and also for visual rehabilitation, so low vision clinics and the like. Branch retinal vein occlusion, same picture. Look at that. Look at this really grotty photoreceptor layer there, and this chronic edema with these large cysts that have developed. Again, similar story. Ozurdex sometimes works well for these as well, steroid implant. How much vision comes back? It's a little bit hit and miss. So here's another CRVO picture. And again, these sort of large tubular cysts in the retina. With this, if this is a new presentation, you want to see it quite quickly, because this eye is very likely to develop new vessels. So if this is a new presentation, they haven't had any problems before, suddenly get this, the development of macular edema like this often signals the transition to an ischemic vein occlusion. And you do want to see the patient to check for neovascularization. So branch retinal artery occlusion. Now, can you see on the photo actually this time, there's a pale area just above that fovea, and in the photoreceptor layer, there's this really bright, thick nerve fiber layer, really white on that side. And it's sort of, it's fairly subtle, it's not very obvious, but actually we consider this quite urgent, quite a bit of an emergency. I'm going to put 2 red flags there. The reason for that is because this can be a harbinger of other significant vascular events, including things like stroke. So you do want to check their vascular risk factors rather rapidly. And this can be associated with progressive ischemia throughout the rest of the system. But you wouldn't see that often. So 24 hours. So this is a sort of eye casualty referral, really. I'm sure everyone has seen this at some point, the post-surgical macular edema. This is very typical. It's got these long sort of tubules again. And the history here will give it away. Always speak to the patient about the timing of the development of it. So if they had their cataract surgery, everything was going fine, and then suddenly their vision starts to get worse, and this is the picture that you see. So we do want to see this, but it's not an emergency. It's not urgent. We've got time to play with. We don't want to keep it for months and months, but as long as you treat it within 2-3 months, you know, you'll give them usually anti-inflammatories, and a lot of them will settle. We're on to our second poll. So we will launch that. This is our little fun one I thought I would do. I like how a lot of people think that it's none of these because they all sound so ridiculous. So, okay, I might end it and share. So there we go. So I was a little bit sneaky with this. I kept saying all these long tubular structures. They are tubular. That's how we describe them. We describe them as tubular, but the term originates from some very obviously romantic ophthalmologist who originally came up with it. Because The actual term is petaloid, like the petals of this lovely daisy you see. You can, with an eye of faith, perhaps see that. I can't particularly convince myself, but that is the term we use for cystoid macular edema. When we look at the picture, it's said to be a petaloid appearance. Now, here's my post-VR surgery slide. So at the end of the section, I'll just pause quickly and see if there's any questions, but this is my post-VR surgery slide. So this is my patient. This is my patient from about a month ago. The top picture is his epiretinal membrane. There's the bright line on top with some cysts. These cysts are tractional. So a membrane's pulling and it's physically pulling open spaces inside the retina. Fluid is accumulating in them, but it's not a macular edema per se. The mechanism is different. The bottom picture is him 2 weeks after surgery. So he looks pretty much exactly the same, except he hasn't got the membrane anymore. And this is the stage when I often get these patients back. I referred back going, oh, this patient has macular edema. Actually, he doesn't. This is just the fact that his retina is taking time to relax because his membrane had been there for months and possibly years, and I've taken it away, and it's going to take months for that retina to fully sit back down. And so this is not a retinal macular edema per se. So usually there's no need to refer. Usually you just watch them and they settle. So before we move on to the next section, I just want to check the Q&A in case there's, yep, so it will be available for playback. How do we know if it's intraretinal cyst or exactly? Well, that's just what I was saying to you now. There's no way to know if it's an intraretinal cyst or just a space, because you work it out from the context. Like my post-operative patient there, if they hadn't had VR surgery and you just saw the second picture, you might think it was a macular edema post-cataract or related to something else. It's all in the context. And it's all comparison, one scan to the next. You missed the pedal slide and answer to question one. Question one answer was cataract surgery. So having had cataract surgery in the past is not a risk factor for developing diabetic macular edema. And the petal slide, I shall demonstrate for your viewing pleasure. This is the petal slide with the questions. Lovely. So have we got any more for any more? That's fine. We answered that, and we answered that, and we answered that. Lovely. So I'll crack on with the next bit. So we're going to talk about macular degeneration. This, of course, is the other biggie in terms of OCT-based diagnosis. We're very much OCT-based now. Nobody is going to diagnose your macular degeneration without an OCT, and often without an angio-OCT on the side. Here's your lovely age-related maculopathy with lots of drusen and pigmentary changes at the macula. This is dry AMD with geographic atrophy. So that big spot in the middle is where your structures are beginning to atrophy and you're starting to lose retinal tissue. And this, of course, is wet AMD. As soon as you have blood, that is wet AMD. So, and then also, of course, blood and fluid showing up on your scans. And they can move freely one between the other. I mean, your geographic atrophy is not going to go back to vanilla dry AMD, but it can go back and forth between wet. So this is dry, and this is all dry. We see lots of these lumps and bumps, and it often can be quite scary to say, well, to confidently say, look, there's no choroidal neovascular membranes, there's no wet AMD there. It's scary because you see these lumps and bumps and they look quite dramatic. But all of this is dry because the retina, look at your photoreceptor layers, which is sitting on top there, photoreceptor layers sitting on top. They can look a bit grotty, but there's no gap between them and the layers underneath. And there's also no fluid-filled cysts within the retina. Therefore, it's dry. So all these pigment epithelial detachments, all these drusen and lumps and bumps, that's pigment migration, that's not wet macula. So we usually don't need to see this. These patients need supportive treatment. They need low vision clinic appointments, and sometimes they may need low vision registration, so we'll see those. Again, dry AMD, but this just shows so nicely. This is geographic atrophy, and you can see how in that area you've completely lost all of your outer retinal layers, not just the photoreceptors, but all of the associated supportive structures with them. And you've got this top layer sagging through and sitting on the bare RP. Here's another scan through a geographic atrophy area. And you can see actually how the choroid glows much brighter underneath. That's not because the choroid's different, that's just because the signal from the OCT machine is passing through a thinner layer of tissue, and therefore a higher signal density is getting back to you. So that's why it looks brighter, because there's less stuff sitting on top to block the light. And again, this we don't really need to see because there's nothing we can do about it, sadly, because it's had its moment. This is the wet. So this is the one that everyone's seen and knows as well. You've got here, we have our fluid-filled spaces. And what are these little bright spots here and there? Well, they are actually photoreceptors that have been torn in half. They've been torn in half by the stretch of this retina. They've physically been avulsed. So you can see how, even if we can dry it out and sit this retina back down, the patient's not going to have great vision afterwards because you've damaged all those photoreceptors that you've physically avulsed. And this, of course, is a sort of a 2-week referral. This is urgent because we need to get treatment on board to prevent further visual deterioration. And this is what happens to one of those after a little while. Turns into a scar. There's not really much fluid about. I mean, there's little cysts, but these little cysts in chronic AMD they're chronic. They're not going to go away. They're not really a sign of disease activity. They're just sort of empty spaces. You get this heaped up scar, which you see as the white stuff. You get these outer retinal tubulations as all the organization and structure of the retina becomes disorganized. We don't need to see this again unless there's fresh bleeding and unless there's fresh fluid that's developing compared to the previous scans. So just a little check of the Q&A. The bottom traction is the bottom traction. Oh, this is flat and see my around. So my answer to this, the question about traction, CMO and pseudocysts, flat versus round, I would try not to get fixed on descriptive terms because they'll lead you astray. Try to think about mechanistic terms. What is actually happening? And, you know, those sort of long tubulations like you see in CMO and some of the macular edemas, that's the stretching of retinal fibers. So you see that, and you can see that the mechanism is kind of the swelling is being pushed up from underneath. The round CMO, I mean, it's almost an argument to say that that is because the round CMO cysts haven't had time to elongate because we treat it. If you don't treat CMO and you leave it, and I've seen some sort of long-standing CMO or CMO that's been missed, they also turn into these long tubulations. So it's all mechanistic, okay? So what's interesting? Yeah, so intraretinal fluid, intraretinal space, it's the same thing. If you think about it, it's the same thing. The reason it's the same thing is because if you intraretinal spaces get filled with intraretinal fluid, okay? The body doesn't like a vacuum. We can't have just empty space in our body because our body is water, which is why if we put gas in the eye, it disappears because the body doesn't like empty space. And so any empty space, if you get a structure that sort of gets degraded or disappears inside the retina, it just gets filled up with fluid. So intraretinal fluid fills intraretinal spaces, whatever the reason for the formation of the intraretinal space. Sometimes the intraretinal space comes first through atrophy of structures, fills up with fluid. Sometimes the fluid expands through just edematous changes and creates intraretinal spaces. D. Yes, the little section. Now, this question, I'm going to actually go back to the slide it relates to. I know exactly what you mean. I know exactly the slide you mean. there is a little, so there's a little black space just there, and on the next slide as well. How do we know that's not fluid? You just have to at some point put your foot down and say, is this likely to be significant? And this is not likely to be significant. If this was a larger pocket, say it was sort of 3 times as large, you might think it was significant, especially if it was new compared to a previous scan. But this tiny thing, you know, this is probably just the draping of the layers over that lumpy, bumpy PED. So you just make a judgment call. This is what we do. There's no magic in it. We just make a judgment call. Is this likely to be significant? Or is this just sort of an artifact of imaging? Is this just an artifact of the anatomy? Why refer with low vision clinic with drusen? Because low vision clinic tries to maximize the vision they've got. And patients with this drusenoid picture, that for instance, what we've got on the screen now, they can actually have visual impairment. So I saw a lady today that precisely had this picture, and she was 6'12". And 6'12", you know, some people manage very well with that, but some people are quite symptomatic. So I still might refer if they were having significant problems. You can have, even without significant geographic atrophy, you can still have visual impairment from AMD. So how does membrane and CNV? How does SRH? No. So I'm not quite sure what you're referring to. The difference between CNV and is that subretinal hemorrhage? Is that what you mean? So if you mean subretinal hemorrhage, that's my favorite topic. I'm not going to cover it very much in this. I've got a whole separate talk on that. But the answer is you look clinically. You look at the patient clinically, and if it's red, it's subretinal hemorrhage. And if it's white, with a little few perhaps red specks, then it's choroidal neovascular membrane. That's the simple answer. So yeah, dementia patients, it is difficult. It's very difficult. And this again comes down to sort of a practical point. When you have a patient who's got limited capacity, limited mobility, limited sort of interactions, you need to think about the patient, not about their eyes. What is going to help them? So for instance, if a dementia patient is very upset by wearing glasses and keeps throwing them off, I will not give them glasses, because it is more, it is a better environment for them to not have to do that. Equally, you ask what the patient does. If the patient likes to watch TV, likes to do puzzles, you know, then their vision is, you know, quite an important factor of that. If they're not really engaging very much, and the vision starts to drop and their behavior doesn't really change, then there's less indication for intervention. So I had a patient recently, actually a dementia sufferer from a nursing home, who used to be independent, walked around, ate his meals, didn't really communicate. But he stopped eating his meals because he couldn't see the fork, he couldn't see to cut his food. And he bumped into walls. We did his cataracts and he did much better. He was much more orientated. So it's that functional aspect that you need to think about with these patients. Differentiating between exudates and pigment migration. Yeah. So pigment migration, you will see usually as dark spots. So on this picture, those little RP changes, those little dark spots near the fovea, that will usually be pigment migration, whereas exudates are usually white, but they do look sort of similar on OCT pictures. They do. So you again correlate with the clinical picture with the color photo. That's fine. Yeah, hyperreflective material in CNV, it is difficult. And this is why we have all the adjuncts which we do in eye clinic, which you don't do, which is the angio-OCT and the fundus fluorescein angiography, because we can look at that same picture, and there might not be very much fluid or any at all, but there's this heaped white material, and we think usually it is CNV. Usually it's CNV, but is it active or not? That's the question. And that's when you do your dynamic studies. That's when you're going to do your angio-OCT or your FFA, because that's going to show if there's actual leakage from that or if it's just all turned into this hyperreflective scar. So that's I'm afraid that's going to be more for us to differentiate, and it's difficult. photobiomodulation. So photobiomodulation, I think you've probably lost me there. I'm not quite sure what you mean. I think if Christopher Kerr can elaborate on his question, I will answer it, but I think you're losing me. You know more than I do.
Would you like me to allow him to talk?
We'll perhaps let him type out an explanation, and I'll answer Wahid Rahman. What about next to large drusen? I know. Everyone's looking for little bits of subretinal fluid now. Yeah, so again, it's all contextual. You look at the patient, you look at the fundus, you look at the picture and the OCT together, and then you ask yourself the question, is this likely to be clinically significant, visually significant? And you know, to be honest, if in doubt, we don't mind a referral. We don't mind cross-checking because it is so serious. We never mind to double check. You know, we won't ever tell you. Or sometimes if you've sent the scan across and we've had a look at the scan, we can tell you we think it's this or that. So that can be really helpful. And that can sometimes avoid an appointment as well. So I'm just going to move on for now. I've got a few other bits to cover and I'll come back to the Q&A a bit later and see if there's anything in chat. That's fine. Okay, so we were up to burnt out. Good. And we were moving on to the CSRs and my favorite retinal detachments. Now, there's not very much to say about these on OCT. They look pretty exciting, but you usually don't need an OCT to diagnose them. We're just going to do another poll to liven things up. So let's bring up question 3. Child with eczema is winning. Looking at the sun is coming in second. Everyone knows about the other ones, it seems. There's not many getting put off by those. Okay, very good. Right, I'm going to pause that. We're going to share results. So, having a child with eczema is actually a risk factor. And I'll tell you how it's a risk factor. If you have a child with eczema, you're often putting on steroid cream to the child's skin. And we forget to ask CSR patients about steroid exposure in others. If you're putting your steroid cream on your child, you're often forgetting to wash your hands, you're rubbing your eyes, hey presto. Everybody knows it's more common in males, and the stress. Now, the stress is interesting. What is stress? Well, stress is the same steroids, but it's endogenous steroids. It's the steroids that your body makes in response to stress. Whereas the eczema and the taking corticosteroids for asthma, that increases CSR risk because you're taking steroids in from the outside. Looking at the sun is not a risk factor. That is a risk factor of something else, which is solar retinopathy. So you get this very pinpoint, sharp lesion in the outer retinal layers, just affecting the photoreceptors. That is almost pathognomonic of solar retinopathy when you looked at the sun. And you have the odd patient like this turning up. Right, I'm just going to briefly check questions. Yes, I thought you might mean that, but I just want to double check. Christopher Kerr about the new energy technique for AMD for Optos. You know what? We're very suspicious folk, our doctors and ophthalmologists, not exempt. We want to see lots of evidence. We want to see lots of evidence of it working. It's kind of a little bit similar, perhaps to, well, actually less similar to the subthreshold laser that's been marketed. Some people swear by it and others are a lot less skeptical. And the reason for that is because there's not a huge body of evidence for it yet, like there is for things like anti-VEGF treatment. So I'm not saying no, but I just want to watch the space and see more evidence coming out. All right. And the chat. Someone's not getting registered. Sorry, it might be because I stopped the poll a bit early, because I was just keenly aware of the time and wanted to keep us moving. I will keep the next poll up for longer to give everyone a chance to express themselves. Okay, so CSR. Here we are, central blurring, male, corticosteroid use, stress, that's your endogenous steroids. It's usually self-limiting within about 3 months. So within about 3-4 months, it usually goes away. And we do want to see it routinely. And usually by the time they get to clinic, they have a tiny little sliver of fluid left, and we'll follow them up in a few months, and they come back and they're completely dry with a little perturbation of the RP layer. You can, of course, get chronic CSR, and these are the kind of the, again, another heart saint group, because there's not very much we can do. There's no treatment that works very well. Lots of treatments tried, but none of them very effective. But this is the OCT picture you see. So again, you see this kind of disruption of the photoreceptor layer. It's all grainy, it's all bumpy, with this central bump. It can be extra foveal, of course, it can be paracentral. And here is a nice picture of a retina schisis versus a detachment. So what is the big difference between these? Why are we concerned about one and not concerned about the other? Well, the picture on the left, you can see that it's a myope, or in any case, an amblyop, because of this deep staphyloma. The back of the eye is very bowed, and that bowing creates forces that are different to a normally curved eye. And if you get an epiretinal membranes are pretty common. 10 to 15% of people get them. If you get an epiretinal membrane across this very bowed retina, it creates a bowstring effect, and it literally pulls the retina up tight like a bowstring across the staphyloma. So this is a myopic macular schisis. It's a central one. You can get the peripheral schisis, of course. You'll see these very dramatic pictures on OCT. But their vision can be great. I mean, this patient, I wouldn't be surprised if they were seeing 6/9. And do we do anything? No, we do watch, because they can progress, but unfortunately, surgical intervention is not very effective in these, unfortunately, and we only operate when they're inexorably progressing and they desperately want to try to do something, in which case we can try a vitrectomy. So this one, you would actually sit on it. If the patient's very concerned, or if you want to double check, we're happy to see, but it's a perfectly routine thing. The picture on the right is not. When you see all the layers of the retina lifted up like that, that's a retinal detachment. And that, of course, is an emergency unless proven otherwise. There are non-emergency detachments, but that's really for us to differentiate, because you need to put all the detachment factors together to determine that. These are some pictures. They're not great pictures because these are very difficult to image, because these schises are usually very peripheral. So you're taking OCTs at the very edge of the retina. But the top two are borrowed from a colleague, so you can see the retina is split. The top layer of the retina goes all the way up there and out of view. That's the roof of your schisis. Off it goes, and the bottom of the retina has stuck, and here it is. There's a great big schisis cavity in the middle. This bottom one I quite like. This is one of my patients, and you can just see these little dots of retinal tissue at the top as the outer leaf, and the lower leaf is sitting here, and these gaps are outer leaf breaks. So they're the holes you quite clearly see in retinal schisis patients, but they're not through and through holes. They're not full retinal holes, and therefore we do not worry about them. We just see them, in the inner leaf breaks. We just see them on OCT as very dramatic findings. You can get similar breaks in the outer leaf breaks, and it's only a problem if the inner retinal leaf break combines with an outer, and then you can get a complete detachment. That's just out of interest. So quickly running through the vitreoretinal interface. This is my obviously my pet subject as well. Here's a nice epiretinal membrane. You can see a lot of this vascular distortion. You can see this one with bulk, and here is an epiretinal membrane OCT. There's a nice bright line on top. You've got loss of the retinal contour, loss of the foveal pit. So this is taken through the fovea, and it's a bump rather than a dip. Now, you can't really tell by looking at membranes how good the vision is going to be, but you can generally assume that the worse the picture, the worse the vision, generally. Doesn't always bear out. So here's some nice cysts. These are again tractional cysts where the membrane's pulling. This is almost a sort of a VMT situation, but the traction is not from the vitreous, but rather from the membrane. And there's a little membrane here, you can just about see it on top, but it's following the contour of the retina so nicely, and it's so thin and pliable, it's not doing any distorting, it's sitting there, and the vision's actually good. So here's our big question. I'm going to put this up and leave it up for a while for everyone to have a good read. This is a clinical one. Have a read and a think. So one answer is much more correct than all the others. I do love my red herrings. Keeps everyone on their toes in this late hour. Good, I think we're getting there. I think the poll has slowed right down. So I'm just going to give it another 5 seconds. And going, gone. So Sheraz, I'm very happy to see the results of this poll. I am thrilled to see the results of this poll because you do have a winner for us, which is number 2, which is my best candidate for an ERM peel. I'll just briefly go through these because clinical cases are interesting, to me at least. You're all going to have to follow along on this. So an 82-year-old lady with bilateral ERMs and cataracts and complaining of blurred vision. If one of these comes to my clinic, and this is about half of every one of my clinics, I always ask them what their symptoms are. If they mention distortion without prompting, that's an immediate flashing light. Their membrane is likely to be symptomatic. If they just talk about blurring and they've got cataracts and they've got one of these unimpressive looking membranes, I will always choose to do the cataract first because 95% of the time they're thrilled and they don't want anything more. Number 2, yes, so this is your classic symptomatic membrane distortion, visual reduction, and a relatively young patient as well. It generally bears out. 38-year-old with uveitis, of course, uveitis makes epiretinal membranes more likely. So that is absolutely true. They might have it. They have bilateral ERM, but the vision is very good, and the symptoms are glare. Glare is probably coming from the early cataract, maybe some of their posterior synechia. It's almost certainly not related to the ERM. You're not going to touch the back of their eye and give them more inflammation and more uveitis problems. 68-year-old diabetic with bilateral ERM, long history of diabetic macular edema that everyone's given up on because it's not getting better. Rubbish vision, you're not going to touch this patient because their limiting factor in their vision is going to be their photoreceptors, which are sick. It'll be one of those really grotty OCTs, and peeling the membrane is going to do nothing for them except perhaps give them some macular edema and make things worse. And then 57-year-old successful vitrectomy for macular off-retinal detachment, objects looking smaller, bit of distortion, bit of membrane. I'm very cautious about operating on these. There'll be some post-vitrectomy patients who get a thick epiretinal membrane that I will operate on. But generally, the macular off-retinal detachment is what causes their difference in object size, because when the retina detaches, it stretches. and all the photoreceptors get further apart. And so the image that is falling on a normal eye is going to fall across more photoreceptors than the image falling across the previously detached eye. And therefore the image from this eye will look bigger than this one. It's comparative number of photoreceptors involved in seeing the same object. And that's what the brain can't reconcile. So this one I probably wouldn't touch, or would be cautious. I would observe, I would see how their symptoms progressed. So we're getting towards the end. Vitreomacular interface is never complete without vitreomacular adhesion and vitreomacular traction. And they're basically the same thing, but one is a more progressed version of the other. Adhesion is just where you get a bit of stickiness of the vitreous at the macula. There's no distortion of the layers. You have preservation of the foveal pit. Traction is where it's doing a bit of work, it's doing a bit of lifting. You can see those really stretched retinal tissues. So this one is probably going to be symptomatic. Now, mind you, you can get these dramatic pictures as well. And if their outer retina is relatively preserved, like this one, they may have very few symptoms. They may actually have no symptoms. I've come across that quite a lot. You want to, again, pay close attention to this outer retinal layer more than anything dramatic going on top. So left one, we don't really mind. It's often pigs off by itself. It's asymptomatic. This one we do want to see, but routinely, because again, they often don't have symptoms. Macular hole, this one's quite obvious, no real explanations required. Sort of routine, semi-routine referral. I mean, it depends on your local practices. I wouldn't want this sitting in the inbox for sort of 6 to 9 months, but we'll see within 2-3 months usually, because you do want to do surgery within a few months, really, ideally. The reason for that is because there's an over 90, probably over 95% success rate, both in terms of improving vision and improving anatomy, if you operate on macular holes less than a year of duration. And the success factors also depend on the size, less than 400 microns. That's again related to time usually, because usually the longer standing ones are bigger. Less than 12-month history, patient ethnicity. So unfortunately, this does play a role. So Afro-Caribbean macular holes don't close as well, unfortunately, and end up more readers. We don't know what that is, why that is. Slightly different protein structure, not sure. Slightly different retinal compliance, perhaps. And also traumatic holes are a problem, but traumatic holes often do close by themselves in the first few weeks. So here is, yes, this is my other favorite topic actually. Pseudoholes and lamella holes. They look very similar. They can look pretty identical in OCT. This is actually, so this is not actually a true lamella hole on the right. Well, it is a true lamella hole, but it's a slightly complicated picture. The left one shows a pseudohole. You have an epiretinal membrane sitting on top. The epiretinal membrane is distorting the tissues and it's creating this sharp edge, sharp cliff. So it's not actually any kind of split of the layers or a hole. It's just a distortion. And so I don't like calling these pseudoholes. I just like calling this epiretinal membrane with distortion. And these, if they're symptomatic, are often amenable to surgery because you remove the membrane, the retina flattens out, it looks nice. The right-hand one is probably a pseudohole that has progressed. So you've got this excavation of tissues and this big lamella pocket. It's also got a membrane, which is why I think it started as a pseudohole. But a true lamella hole often doesn't have a membrane, it's just got this excavation. Now this is definitely non-surgical, because even if you peel this membrane, it wouldn't get better. And if there's no membrane, then there's nothing to do. There's nothing you can do to encourage this retina to look nice. The degenerative lamella holes often have a very good vision or very minimal visual impairment. And they tend not to progress over time. I also don't like calling these lamella holes because you say hole to a patient and the patient gets very, very worried. And then I have to spend half of my clinic appointment convincing them they don't have a hole in their eye. So I like to call them lamella defects or skies. I mean, that's essentially what they are, but I like to use less scary terms for patients. So we're not worried about these particularly, unless the patient's very symptomatic, in which case we're happy to have a chat with them. And all of these conditions, they're interrelated, remember. So normal retina can make a pseudohole, which can turn into a lamellar hole, which can turn into full thickness. But not there's progressively fewer and fewer eyes that complete this pathway. A lot of them stay at these earlier stages, and it's proportionally a small proportion that that progress. I'm just going to have a quick look at the questions, so that's fine. Do I want all macular holes referred routinely? Yes, pretty much, unless they're traumatic. If you get a, say you get a young chap who gets a football to the eye and they have a macular hole on their OCT, that one I do want to see straight away. But to be honest, I'll probably be seeing that anyway because of the other aspects of the trauma, the probable high FEMO or high pressure or vitreous hemorrhage or whatever else they've got in association. All other macular holes, yes, routinely. The one thing that's useful to see on the referral, if possible, is the duration. If you can ask the patient how long they've been noticing the symptoms, to be honest, often it's you guys that pick the symptoms up and the patient may not have noticed, in which case it's difficult to know. In which case it's up to us to look at the morphology of the hole on the OCT and decide if it looks more chronic, what are the outcomes going to be likely to be, and we can discuss that with the patient and counsel them. Okay. Right, so we're just going to go back a little bit to CSR in the questions because I've got some here. How is CSR managed in the heads? With a hug and a pat on the back, to be frank, because as I mentioned, unfortunately, we don't have anything good for CSR. Now, I did a medical fellowship, medical retina fellowship in Moorfields, and we had a whole clinic full of CSR patients. And those were the chronic ones that either didn't resolve or kept coming back, and the vision would keep drifting down. And in those, we would start trying things. And we would try the spironolactone, and we would try PDT and a filhaiken. The truth is, none of it works great. I've seen PDT improve vision by 1 line, which consequently, over the next few months, regressed straight back down again, and it didn't work again. Some people are trying the subthreshold laser. So for example, the Quantel laser has a subthreshold, which is just like a gentle tickle. It's less than the focal laser for diabetic macular edema, which is supposed to do something to reduce it. But there's no good evidence that any of it works very well. So we try everything to let the patient sort of feel like we have. And occasionally you can get a tiny bit of an effect. Annotated notes, yes, that would be great. That would require me to write them. We could transcribe the webinar if we have manpower for that. That would be good. Is it normal to have hyperreflective material above the RP in long-standing CSR? How can you differentiate from other types? Yeah, so CSR can be confused with AMD. They're both essentially fluid under the retina, aren't they? And they both get little bright bits. Again, as with so many things, it's going back to the demographics and the history. You're not going to get AMD in a 35-year-old male bodybuilder. I mean, you might, but that would be a really good case report. So it's all going back to the clinical scenario and the patient in front of you. We all have a tendency. We love visual things. Ophthalmologists, we adore our scans. We love to be glued to them. You have to actually turn around and look at your patient and think clinically and put all the bits of evidence together. And that's the way to differentiate. Does VMT cause lamellar macular hole? It can do. It can do. It's attraction, isn't it? So you've got the layers, you've got pull on the top layer, it can sort of lift it up, and there you go. And there's your lamellar defect. But lamellar defects, I'm not going to call them lamellar holes, I'm going to call them lamellar defects. They also form just a general degeneration of the retina. You don't need traction. I mean, there may have been a bit of traction at the beginning, but they can progress without. That's fine. If the patient might off a retinal detachment in one eye, significant ERM in the other eye, would you operate? So, you know what? If they have a significant ERM in the other eye, I will be highly suspicious that they've had a retinal tear in that other eye, because that, of course, increases the risk of ERM. So I will look really careful in the periphery for a retinal tear. Now, that retinal tear will be old because it takes time to form the ERM. But an ERM will not cause an RD. you can get tractional detachments, but you need one heck of a pull to detach the retina. The retina gets stuck to the RP by a very powerful pump, which pumps water out from the subretinal space. You need one heck of a pull to overcome that pump like in a tractional detachment. So retinal detachment is generally caused by a hole somewhere, a hole caused by a PVD. Now an ERM is just going to sit there. It's not going to cause significant traction, significant enough to detach the retina. One, I guess, small caveat is in that highly myopic staphyloma we were talking about, in which case you get that bowstringing, in which case you get the schisis, and that schisis can sometimes become a detachment. So I would operate on the ERM if their vision was down and they were symptomatic of distortion. That's when I would offer them surgery for their ERM. I wouldn't be swayed by detachment in the other eye really. What causes lamellar macular holes? So we don't fully understand. All of these vitreomacular interface disorders, we think that the vitreous retinal interaction plays some role in them, but we don't fully understand what role, because as I said, with lamellar holes, you often don't see any traction with them. Is it that the traction happened earlier to initiate it, and then the split has just kind of gradually unzipped? We don't know, because some of them you pick up and you see they get a bit worse without any apparent traction. Maybe our imaging is not good enough to pick up very fine traction yet. We don't know. That's the answer. Lamellar defect. Thank you. Lamellar defect, not hole. I'm retraining people. Do we review in 369? Yeah. What factors dictate? That's a very good question. That's an excellent question. And I really like, do you know why I really like that question? Because you're happy to monitor them and refer them when it's appropriate. I really like that approach. So if I get a lamellar defect referred to me, I will usually discharge them straight away. Unless they've got a tractional element, or it's sort of a schitic element with it, with some ERM on top. I might monitor those maybe for 4 to 6 months. So I would be happy those being monitored 6 or 9 monthly. Doesn't need to be frequent. They don't change very fast at all. And referral is dictated by vision. If the vision keeps dropping, the problem is if they come to us, we can't do anything. Not with degenerative lamellar defect. Surgery doesn't work because it's not a full thickness macular hole. There's no tractional element. There's not much we can do, and so the referral in these cases, we're happy to check, but we're most likely to just recommend low vision. If there's an ERM component, then yes, then I would see, if only just to have a chat with the patient. The occasional one of these is amenable to surgery. So vision drop and symptoms, patient symptoms, doesn't matter what the picture looks like. You're not treating the picture, you're treating the patient. So it doesn't matter what the picture looks like, refer according to symptoms. What causes ERM? Vitreomacular interaction. It goes back to that vitreoretinal interface. It's some sort of interaction at the point of PVD initiation that causes the laying down of these fibrovascular cells. The things that predispose you to ERM, such as your retinal tears, your inflammation, they're all things that release these kind of inflammatory, these fibrotic elements into the vitreous. Funnily enough, a superior retinal tear is more likely to produce an ERM than an inferior one, because gravity will pull all of those inflammatory factors down from the tear onto the macula. So young patient with ERM, slight drop in vision, yes, always assess for tears. Every ERM assess for tears, because if you pick one up, that's brilliant. That's an earlier pickup and we can look at it. But in the young, when you're much less likely to have a PVD in situ, now you might still have a PVD. They might be myopic, or they might have had trauma, or they might have had inflammation, all of which will induce an earlier PVD. But if they've had no history and you've got an ERM, I've had a few patients like this, do always dilate, do check, but not only for tears. A young patient with ERM will often have some sort of vascular anomaly in the periphery, some sort of leakage, or some sort of inflammatory issue. So these ones are really, really important to check. The whole fundus. is it a good idea for leaving on the fence patients with arms, the charts and kidney? Absolutely, absolutely. As I keep saying, we're treating patients. We're not treating pictures. So if the patient's not very fast, if they're pretty happy, doesn't matter what their pictures look like. Leave them with self-monitoring, tell them to come back. They will come back if they're in trouble. They will come back if they're symptomatic. And this is exactly what we do. And this is what we like doing because I think it's good practice. Right, hang on. Let me just go back in the... Yes, we are running a little over because everyone's really enthusiastic with the questions and I don't want to leave them unanswered. Oh, I know. I should have made the orange and green a bit more obvious. That, you know, that's a cardinal mistake, isn't it? You're supposed to make your presentations all blue and orange. That shall be corrected. But cunningly, the flags are orientated different. The red ones are the straight up ones, and the orange ones are fat and slanted, and the green ones are skinny and slanted. So that might help you. Good. Do you struggle to see nevus? Yeah, I mean, sometimes they're really not very obvious. Do you know when they're obvious? On an Optos image, on one of the wide field photos, and then you go, oh my goodness, I didn't even see that nevus when I was looking clinically. Yeah, they can be hard to see, and they can be hard to see on the OCT because they can be really flat as well. That's fine. Asymptomatic patients with ERM, yes, dilate asymptomatic patients with ERM at least once, just to make sure there's nothing obvious. Treat old superior perculated. We're getting a little bit off the OCT topic. This is one of my previous chats. The answer is old superior percolated tears. It depends. I'm going to leave it at that for now. That might be another talk. That's fine. Good. So I'm just going to briefly skip through the very rest of it because we're right at the end. Little talk about the future. So where are we going to take OCT from here on in? Angio-OCT, we're using it already. It's going to develop more and more and become more useful looking at the different retinal layers and the vascular activity in them. Depth imaging, so that extended depth, swept source OCT, we're going to learn more and more about the choroid. There's a whole host of work now going on about the choroid on OCT, which we could never see before this technology. You know, the pachychoroid conditions and all the rest of it. Machines are going to keep getting better, keep getting higher resolution, keep getting faster. Automation for follow-up. We already have follow-up mapping and some machines where they will auto-compare and auto-track features from previous examinations for patients. Linked up with AI, this is a whole you know, very exciting field for the future for potentially virtual clinics or imaging clinics. And new technologies, I'm sure, will come on the market. That adaptive optics machine I was showing you at the beginning, I mean, I'm really excited about that because you can take a patient. We were looking at retinal degeneration. We were looking at patients with retinitis pigmentosa, you know, patients with chromatopsia. And imaging their individual cone cells, and then visit to visit, you see how the individual cone cells are dying off. Literally, those are cone cells, and now there's a space, and you see them live doing what they do, you know, flickering between their on and off states, and it's amazing. So, in summary, apologies for running over. Everyone was quite involved with the questions. OCT is a visual biopsy of the retina. Always remember the normal anatomy. That scan I kept putting up, always refer back to it. If you're going to look at any layer, look at that photoreceptor layer. That is your answer. What's going on above it is almost irrelevant. It's interesting, but almost irrelevant. Correlate your clinical picture with your OCT. Remember the natural history of the condition and just use sense. That's all we do. We just use common sense. Thank you very much and stay in touch.
Well, thank you very much, Jen. Thank you, all attendees. Thank you, Samar, who's our marketing in the background, who did all the arranging of the talk. And just to quote, one of the attendees said, Evgenia is a genius in her field. And I think that sums it up pretty accurately. And I think, Jen or Evgenia, you have invited yourself back to do another couple of talks in the autumn. I think one of them might have to be on subretinal hemorrhage. And I think we will want to know a bit about angio or OCT in the future as well. Will you accept? Will you come back and lecture again?
I would love to. I would love to.
Fantastic. From a clinical point of view, you have the link to the Survey Monkey, and you go on that to get your 1 CPD point. We will be doing another talk in June, haven't got the precise date yet. That's not going to be retina. The next 2 talks are going to be orthoptics, then pediatric ophthalmology stroke neuro-ophthalmology. And then hopefully back in the autumn, we'll have Jen back again to take us through some more amazing pictures and interaction. Thank you very much for all being involved in this webinar tonight. And thank you, Jen, again.
Thank
Bye-bye
you all
now.
for coming.
Thank you.